I'm Dr. Maryam Lustberg, and I have the honor of co-chairing this session with Professor Koczwara from Australia on this parallel session entitled Why Patients' Voice is Essential for Supportive Care and How to Make It Heard. We have two wonderful keynote speakers. The first speaker is Stacey Tinianov, who is from the US. She's an experienced patient advocate who has been active in multiple advocacy agencies in the US. And she will discuss the why and how of patient advocacy and how we can increase patient engagement and optimize the delivery of cancer supportive care. Then our second speaker is Pietro Presti from Italy, who comes to us from the European Cancer Patient Coalition. And he will speak on the current issues surrounding patient advocacy facing European organizations, as well as global initiatives to advance patient engagement in cancer supportive care. And next, my colleague will introduce the preferred papers.
Thank you, Dr. Lustberg. I'm delighted to be joining all of you at this parallel session. My name is Professor Bogda Koczwara from Adelaide, Australia. We have a pleasure of presenting three outstanding Proffered papers that relate to this topic. The details of the presentations and the bios of the speakers are in your conference information, but briefly, the first speaker is Dr. Sam-Okerenta, speaking on the exploration of cancer survivorship experiences of support and care continuity among UK, Black African and Caribbean cancer survivors and their family caregivers. The second presentation is delivered by Associate Professor Wendy Gifford and Ms. Peggy Dick on interventions to improve cancer survivorship among peoples and communities, a systematic review with a narrative synthesis. And the final presentation is by Dr. Elisa Fairchild on teaching students to see through patients' eyes, our 10-year experience with an interprofessional supportive care studentship. So I'd like to welcome you to this outstanding session, and I hope you enjoy it.
Hi, I'm Stacey Tinianov. I'm a patient advocate, and I am here to share a little bit about patient advocacy and the current state of affairs of patient advocacy in North America. These are my disclosures. And first off, I want to start with a thank you. Thank you to MASCC, thank you to the organizing committee, thank you to the committee that organized this particular session. But thank you to all of you for spending your time and your energy learning more about supportive care and cancer, and specifically learning how advocates can and should have a voice in that care. I'm going to start with a little bit about myself and how I got into this space. This is a photo of me and my mother. My mother was diagnosed with breast cancer at the age of 63. The diagnosis came out of nowhere, and like every other individual and family faced with a cancer diagnosis, it was a bit of a shock and it was a complete upheaval. We suddenly had to learn a bunch of new words. We suddenly had to make a bunch of decisions that without medical degrees, we really didn't feel confident in or educated in. At the time, my mother lived in the state of Texas. I lived almost 2,000 miles away in the state of California with my family and husband and young children. And I flew back and forth to try to help her understand some of these terms, help her make some of these choices, to make decisions that were going to be best for her. 6 weeks later, this is me. In between her diagnosis and my first mastectomy, I had what I thought was just going to be a baseline mammogram, and I was diagnosed with breast cancer as well. we had already learned a lot of the terms. We had already, I already knew kind of what was coming down the pike. But what I didn't understand is just how disconnected healthcare and personal care were from each other at that time. I felt like healthcare saw me as a set of symptoms. They saw me as a diagnosis. They were empathic, but they were laser focused on eradicating cancer, where I was also laser focused on eradicating cancer. I was also a working professional. I was a wife, a mother, active. I had hobbies, and I didn't feel seen. I didn't feel heard, and without being seen and heard, I certainly didn't feel held. Why is all of that important? And why is it important today? It's important because when I identify as an advocate, I wasn't born that way. Navigating healthcare for me was really the birth of advocacy, and it was the birth at that time of self-advocacy. There was a standard of care that was offered, and yet it didn't mesh well with what I wanted from a quality of life perspective. The oncology goals were not completely different, but not nearly as comprehensive as the goals that I wanted for my life. So I decided that I could take a little bit of a lead. And why is that important to you? Or why should that be important to you? In North America, there are 19 million and probably more at this time, individuals that are living with a diagnosis or a history of cancer. There's 19 million people that have either gone through a process similar to mine and similar to my mother's, or who are right smack dab in the middle of it. And there are 1.9 million people that will likely be diagnosed. Again, these are North American statistics only this year. And so they will go through a similar process. Every single one of those individuals will need supportive care in cancer. And so I'm here to help share maybe how we can reconsider this, how we can rethink this, and really focus on how advocacy is not just this navigating healthcare into self-advocacy, but advocacy is much bigger. There's multiple types of advocacy, and hopefully many of you have had reason to interface with advocates, patient advocates. So there's the self-advocacy that I just described, and I think it's pretty self-explanatory. And then there's also the broader patient advocacy, and I'll get into that in a little bit. Community advocacy, again, advocating on behalf of a broader community. Research advocacy, and then obviously policy advocacy, because as many changes that we can make and as many things as we can improve at the N of 1 level, a lot of those things don't stick, and those don't become standard until we move policy at the same time. So I like to tell people that as an advocate, I share perspective to shift paradigms. And again, we're all looking at the same problem, but we're looking at it from different perspectives. And I think when we stop and take a deep breath and think about that, I think it really starts to make a lot of sense, not just in oncology, but in life. But is that all we do as advocates? And it's a provocative question, because of course the answer is going to be no. So patient advocates definitely do, I think what a lot of people think of is support individuals one-on-one, and that can be casually. Once you as an individual have a cancer diagnosis, you tend to be the magnet for everybody in your community when they get a diagnosis. You can also do that formally, and some of you may have had interactions with formal patient advocates in the work that you do. Most of us share our stories. Again, there's that perspective element to help individuals understand what it feels like on the other side of that fence. And then we help others share their stories again, because the more personal stories that get out there, the more success stories that get out there, the more how might we better stories that get out there, the more we can start to really change the narrative in cancer care. But probably for this particular conversation, the thing that we also do is we grab a seat and we become a voice at the table. And this is across the board in cancer care, how our diagnoses delivered, how do we use words to communicate things to patient audiences. Where we do it anywhere, anywhere we're allowed in. Patient advocates participate with their local healthcare institutions, oftentimes through patient member advisory councils, sometimes a little bit more specifically, they'll be brought in on specific projects, program improvement projects. Post-care surveys, obviously anybody can participate at this level. Media, social media, I don't know how many of you are active on Twitter, but there is a very focused and broad conversation going on around advocacy, patient advocacy, oncology advocacy, and survivorship advocacy on Twitter. Conferences and symposia like I'm doing today, and then even within industry. So pharmaceutical companies in North America are really starting to understand that they don't want to be perceived as, you know, this money grubbing entity, which in the past has kind of been a perspective. And so they're starting to get the patient voice and integrate that into all things that they're doing. And we do this for many of the same reasons that you do the work that you do. We do want to see personalized treatments, not precision treatments, but personalized treatments. How is this treatment going to affect and how can it be tailored to the individual that is going to receive it? We obviously want to improve care coordination, but most importantly, we want to include outcomes and how those outcomes are defined. Not just a no evidence of disease, but actually a situation where people are able to thrive. And then in situations where individuals don't necessarily have an opportunity for no evidence of disease, how do they navigate living with a metastatic cancer? We're always trying to elevate health and disease literacy and just improve the general patient experience. And most importantly, we really want to facilitate involvement in patient care. And regardless of where you are in the oncology space, as an oncology professional, I think you can see the benefit in people taking an active role in their own care. Research advocates are a little bit different. We like to promote very focused research. So not just breast cancer research, but how do we zero in and focus on metastatic triple negative breast cancer, and how do we share what the need is there? We want to promote relevant research, and I have nothing against yoga. In fact, I try it sometimes, but when you are living in a community where you're just trying to make it to your next birthday, seeing all of these studies about how yoga can help improve some of the side effects of endocrine therapy can be frustrating. And so if that's not necessarily where your priority lies, we want to help individuals promote relevant research. And a lot of that is in the metastatic space. Definitely want to support co-design of research and clinical trials. And this is as much to help the researchers as it is to help the patients. The better designed a clinical trial is, a study is, the better opportunity you are going to have to get that clinical trial recruited. And then obviously sharing research. People work so hard and so long on digging deeply into some of the challenges in the oncology space, and then it stops. Or it doesn't stop and it goes into a peer-reviewed journal that sits behind a firewall. And so the general cancer patient community cannot take advantage of it. Again, we do this through our own health and academic institutions, but we also do this through a lot of federal organizations. So Patient-Centered Outcomes Research Institute, or PCORI, has a variety of panels we all can participate in, and then advocacy organizations as well. Again, we do it to facilitate the acceleration of research and to improve outcomes for people. And I think across the board, our why is really improving outcomes and improving quality of life. And it doesn't matter what type of advocate you are, that is really the focus. Bit of generalization here, but for most advocates, our road is really paved with a common desire to just educate, to learn, and then to educate some more. We want to change the narrative for individuals who are dealing with a cancer diagnosis, who have dealt with a cancer diagnosis, or who are dealing with some really challenging decisions because cancer will likely kill them. We really want to personalize the experience. Again, if you're seeing cancer patients on a day-to-day basis, it sounds like something you probably want to do as well. In North America, particularly, and I'm not well versed, from a global perspective, but the urge to even the playing field. We have a lot of challenges with disparities in care along socioeconomic lines, along racial lines. Access to care, healthcare is not a guarantee in the United States, and that comes with its own challenges. Fundamentally, we want to make sure that these systems, these healthcare systems, these cancer care systems remain protective, but they don't remain paternalistic. The days of an old man in a white coat telling us exactly what we need to do, as opposed to asking us what our goals are really hopefully over, but at this point we'll just say numbered. The challenges that we face, data and knowledge silos, paternalism and ego is probably one of the biggest challenges. Changing a framework that's working for people at the top but not working for people at the bottom is challenging to do. Status quo, we always hear a lot of, well, we've always done it this way. Well, that way is not working as well as it used to anymore. Financial constraints, and then grief and loss. I showed you a picture. I started with a picture of friends and advocates, and a good portion of those people are dead. They have been killed by cancer, and so on a regular basis, while we are trying to move the needle forward, we are dealing with death of friends and fellow advocates. I want to peel back the onion a little bit on what I just shared, because it was a lot of information around kind of where our focus is and where our challenges are. And I do wish this were a live conversation because I would love to get feedback, but I'm kind of at this point willing to bet that the clinical care team and the supportive care team is a very, very similar path. Because I've been able to interface with many of you, I do know that you also have an urge to drive innovation and make change. Otherwise, you would not be participating in this particular conference. I also see in working with many of you that there is a drive to personalize this experience to make sure that individual needs are met, not just population improvements in cancer care. And I also have seen that you deal with many of the challenges that we do, not just status quo and paternalism and ego within your health institutions, but also the financial constraints and fundamentally the grief and the loss. And so again, thank you for putting your efforts into this space, because I know that it comes at a personal cost. Again, similar and overlapping goals. These are the things as advocates that we see and we want to move towards. We do see incremental progress in prognosis. We do see incremental progress in outcomes across the cancer space. But the incremental progress still means that our friends are dying, our family are dying. We really want to see that jump. And I think we are virtual for this particular conference because of a global pandemic, and we saw just how quickly medicine and research and public health can come together to make really amazing things happen. An mRNA vaccine in under a year, Distribution still leaves a little to be wanting in some spaces, but we're getting there. And I think that everybody can agree that it was a monster of a task, and we've risen to the occasion. We want to see that same improvement in outcomes and quality of life in cancer. We absolutely, just like you, we read all the journals. There is an increasing incidence across cancers, and the age of that diagnosis is decreasing. And this is not all on you. This is not all oncology. There are a ton of environmental factors that we probably need to address. And I brought up policy advocacy as well. So we're working on that. But we absolutely want to see a reduction in the number of cancer diagnoses overall, as do you. We do see a higher mortality across the adult and young, adolescent and young adult communities. But most importantly, we are seeing this across communities of color. We're seeing higher mortality. We're seeing worse outcomes. So we're striving to try and achieve health equity in all things, not just cancer. Again, you're focused on survivorship, and so are we, but we really would like to see metastatic survivorship support across all of these areas. And again, fundamentally, we want to see patients as people and partners in their healthcare and research. So again, how can we help you? We have been involved with a variety of things in North America. Survivors teaching students and medical and research teams. We can help with a lot of the translations and reframing. Right now, there's a huge push on de-escalation of treatment. And I have to tell you that from a patient perspective, saying we're going to de-escalate treatment is terrifying, because they think, oh, they're not going to do all that they have to do for us to have the outcomes that we're looking for. And so if you just reframe that to say we're right sizing your treatment or we're personalizing your care, that can make all the difference. Patient failed treatment is incredibly heart-wrenching to individuals whose treatment failed them. And that's really what happened. We can help you with community connections. We know that you're overloaded. We know that healthcare is already overloaded, but we have connections within the community that might be able to take some of that workload off you, especially when we talk about survivorship care and what happens post-active treatment. And then we love to co-design and co-create. We really want to drive patient-partnered research, patient-driven research, and we can help you with lay abstracts, with study design, recruitment, and dissemination of your results. We can also help you define what's relevant to our communities. There are some key concerns across the space every time that we in North America try to say, hey, please let us have a seat at the table. People are afraid that we won't understand, that we would be asking for medical advice, that we want compensation, which I'll get back to that because we do. And then we hear a lot of, but I don't know where to find an advocate. And the reality is, we will understand. We speak research where it matters, and we have educated ourselves to a level where we can translate between you and the patient community. We're not asking for medical advice. We are out to transform the system. And I don't know where to find an advocate. We're everywhere. We are on social media. We are probably at your health institution in a patient family advisory board. But if nothing else, you can find us through advocacy groups. And we have had success. So specifically, patients, advocates, educating clinicians, and med students and researchers. The Ovarian Cancer Research Alliance has a program called Survivors Teaching Students, where survivors have conversations with medical students, sharing their experience to help give that broader perspective to people who are joining the medical field. I'm a member of the Breast Science Advocacy Corps out of UCSF. We talk regularly with researchers around what we're seeing in the community from a needs perspective and a perceptions perspective, where we want to focus research, and then we help them in the same ways that I was articulating on the last slide. We help them with lay abstracts in order to get funding. We help them throughout the study process. and then we help them disseminate the results. Casual engagement, it just leads to good things. It leads to relationships, and relationships really lead to partnerships and collaboration. So we can do that through a variety of different ways. In fact, we're doing it now through MASCC. And then the co-design and co-creation of patient-partnered and patient-driven research. Again, the Count Me In program that originated out of the Broad Institute is patient-driven. Everything that has been created in that program was done in partnership with patients. The ROS1ders, ROS1 is a target for lung cancer for a variety of cancers, and that was a patient-formed group that really has changed the game from a ROS1 perspective, both in helping to create studies, but also to build registries so that more research can be done. And then become Black experience of clinical trials and opportunities for meaningful engagement is a new study that's just popped up again in North America. And so if I were to give you advice, I would say engage advocates early and often, make sure that you have diverse representation, and definitely compensate. The things that you don't want to do, don't think you already have the answers. I mean, if you've been in practice for 40 years, you know an amazing number of things, but you don't know everything because the world has been changing as you have been practicing, and we are happy to share those experiences. Don't request a letter of support 24 hours before a grant proposal's due. I'll just put that out there. I think we don't want box checking. We don't want pretend engagement. We actually want to be partners. And then please don't expect that advocates are going to work for free. Write us into a grant at market rates, pay for travel. There are other ways to compensate. It doesn't always have to be with US dollars. Giving people scholarship to attend a conference. There's a lot of ways that you can make that happen. And then if you do work with people, do work with advocates, update them on the impact that they've had, keep them in the loop. That's why we want to be partners, not just participants or subjects. And then make sure that you don't do anything halfway. Consistent relationship building is really where it's at. So again, thank you. There are many forms of patient advocacy and type of advocates. We are trusted in our communities. We are amazing translators, and we would love to work with you. Oncology professionals and advocates share similar challenges and goals. And I know that your job is different from my job, but I think at the end of the day, we're all looking for the same thing. And then just know, and I think this probably makes sense in all other areas of your life and work, but these partnerships and collaboration really are the key to unlock all sorts of solutions to all of our common challenges. And with that, I thank you. Again, I wish we were face to face. I wish we were in person. I wish I could thank all of you personally, eye to eye, for the work that you do. You are keeping me and many of my friends alive. You did your best to keep other friends alive, well past what could have been an expiration date. And you've done all of this with supportive care. We do feel seen, we do feel heard, and that is the first step to feeling held. And appreciate your time.
Good afternoon to everybody. Thank you very much, MASCC, for inviting me to present my lecture about how can advocacy improve care. I am Vice President of the European Cancer Patient Coalition. First of all, I, Pietro Presti, declare that I have no conflict of interest. I want to present you ACPC, is the European Cancer Patient Umbrella organization established in 2003. Is the largest in Europe. His mission is advocate for patients to be acknowledged and as an equal partner and co-creators of their own health. ACPC works for a Europe of equality, where all Europeans with cancer have timely and affordable access to best treatment and care available throughout their life. Our motto is one voice for cancer patients all over the world. We represent more than 450 members in 38 countries, representing all European member states, and we have important collaboration and partners over the world, South America, North America, and East. We have an important strategic alliance with the main institution and main society at the European level, as EMEA, European Cancer Organization, ACI, European Academy of Cancer Sciences, for example, of course, European Commission, so private and public society and institution at European level. Our strategy for 2019 and 2022 is based upon 5 pillars. First, policy is our important activities. The main objectives is influence the European legal framework and the European international political agenda. Research to increase the role of patients in cancer research as co-researchers. Education and capacity building to empower members to shape national cancer policy and demonstrate their abilities to better serve cancer patients. Of course, communication, important to raise awareness on main challenges faced by the patient to access innovation and other resources available for cancer patients. At the end, of course, governance. It's important to build a sustainable model for governance and cooperation with its members. These are our priorities for the next 2 years, 2020, 2021. First, access preventive and novel cancer therapies, survivorship, care and social disparities, rare cancer, cancer research, cancer comorbidities, cancer and COVID-19, and patient safety, healthy living, and digital innovation. As you can see, starting from 2014, the ACPC did a lot of work in advocacy activity. We started with the Immuno-Oncology Policy Action Framework, the European Cancer Patient Bill of Rights, very important milestone. In 2015, we launched the white paper on challenging the Europe of disparities in cancer, European Parliament Declaration on World Cancer Day, and the European Parliament written declaration on the rights of cancer patients. Another important milestone in 2016 was about a white paper on the value of innovation in oncology, and it changed the European regulation 726/2004. In the year next, 2017, we respond to the European Commission consultation on HTA cooperation. We launched ACPC position, EU option for improving access to medicines, and the CANCON joint action on cancer control and white paper on cancer carriers. And other important activities in 2018, 2019 on HTA, for example, position paper, and other important activity on, for example, on work-life balance, and recommendation on JARC, and launch the first MCE's Awareness Day. So our milestone, our advocacy to improve cancer is based on different activity, different fields that impact on the cancer care, on the quality of life, on quality of treatment of cancer patients. HTA is very important, personalized medicine, right to be forgotten, CAR-T treatments, or cancer-related complications, comorbidities, in melanoma skin cancer, immuno-oncology, port update, rare cancers. For this year, these new activities are represented by digital health, cancer inequalities, palliative and complementary care, challenge cancer parenting intergroup, cancer mission, European Betting Cancer Plan. In terms of capacity building and awareness raising, we organize and manage annual congress guides with ESMO patient guides and ESMO survivorship guide, make sense of head and neck cancer, nutrition, sport and physical activity for cancer patients during the and after treatment, COVID-19 awareness campaigns. So Here, there are some examples of our activity in terms of advocacy and capacity building. Our annual Congress is a fundamental event where ACPC meets all its members and partners. It is a unique opportunity to engage in capacity building and networking. The next ACPC Annual Congress is planned for June 2021. Our aim is to create a sense of community among our members, to give members new resources and ideas in terms of capacity building, making it the major event for cancer patients in Europe. Another important campaign is about head and neck. It has been observed that there is a significant lack of awareness of head and neck cancer in Europe, demonstrating a clear need for further education. Nearly 2/3 of all head and neck cancers are diagnosed at an advanced stage, and only 10% of patients show metastasis and disease size from the first presentation. So our aims for our neck and head cancer campaign is to raise awareness through a social media campaign and webinar, communicate the discrepancy in care between the member states of Europe, and adapt the existing head and neck cancer survivorship guidelines. Nutrition. Nutrition is a crucial component of cancer treatment and rehabilitation. Unfortunately, it is often neglected, leaving patients and their families with doubts, questions, on the need for practical guidance. Nutrition and physical activity awareness month is celebrated every day in March. Another very important campaign in terms of awareness is a sport and physical activity. Numerous studies highlight the effectiveness of physical exercise in the cancer patient's pathway, also to reduce the number of intensity of side effects. Despite the evidence, training is not yet considered an indication for cancer patients, while physical activity levels tend to decrease during treatment, remain low after treatment. So our aims for nutrition is update, disseminate the evidence-based patient guidelines and organize webinars. Second, to promote the Charter of Rights at national levels and update the booklet addressing cancer patient concerns. For sports and physical activity, our object is including physical exercise in clinical practice as a therapy, breaking down barriers to prevent recommending physical activity to patients, and of course, publish a literary review, a brochure in this field. Unfortunately, we faced from the last year COVID-19, and the coronavirus has spread around the planet, sending billions of people into lockdown as health services struggle to cope. ACPC is committed to provide the cancer community with the most current information to ensure that cancer patients are safe and protected. So we launched the COVID-19 web hub and guidelines, several results and gaps identified through our activity. Our aims to continue to support and monitoring irregularities in terms of treatment for patients. A set of patient stories will be published. HTA, Health Technology Assessment. ACPC strives to enable and empower members to urge national policymakers to protect cancer patient rights to participate in HTA bodies and advocate for a formalized framework of patients involvement in the UA HTA at national and regional levels. So we need to equipping patients at national level to be ready to participate in the HTA process. We need also to informing policy makers on the effectiveness of involving patients. And at last, translating the HTA tool and organizing webinars at national level. Another important fields that are emergent in cancer care and need to the involvement of cancer patients is personalized medicine. It represents a new era in the field of oncology, require decision based on each person's individual profile and the characteristic with the ultimate goal to improve patient prognosis and quality of life. It's important to have awareness about molecular and genetic tumor profiling remains low. So we need to build a vital bridge between all the relevant stakeholders, put PM for cancer into spotlight of European and national agenda, and of course, advocate for a common European policy about personalized medicine. Another important activity is communication and sensibilization. For the 2021, we had several social media campaigns. An example is nutrition campaign based on March, bladder cancer campaign, Merkel cell carcinoma campaign, Cancer Week, Cancer Survivorship Day, non-melanoma skin cancer campaign, and a neck cancer campaign, and personalized medicine campaign. They are cycle campaign that repeat each year, and each often in different months over the year. Here you see some example of this campaign is communication, our communication activity. Other example, a CPC project, for example, is cancer and inequalities. The large disparities in European cancer care, both among and within countries, remain a long-term priority for CPC. Palliative and complementary care is a fundamental component of the cancer patient journey, but it is often neglected. Digital health, with the world now becoming more and more digital and the citizen of the world more and more mobile, there is a need to be able to access your health data and be in control of when, where, and how you want to share it in order to always keep your health data updated. And challenge cancer parliamentary intergroup on cancer is very important policy activities and result for ACPC. Is a forum for members of the European Parliament from all political parties to engage in dialogue with patients, cancer survivors and carers, scientific and medical societies, research institutions, think tanks, medical practitioners and research policymakers and leaders of the health industry, civil society at large, national government institutions to create a continuous dialogue, continuous engagement of these important stakeholders at European level, at policy level, and of course at advocacy level. So as you can see, advocacy activity and strategy needs to base on specific pillars. As ACPC, we are continuing to draft, design important project activity to raise the voice of cancer patients across Europe, and not only, together with the main stakeholders at the political level, at pharma industry level, at, of course, our member and policymaker. We need to increase the capacity building of association to improve cancer care. All cancer care pathway to embrace the entire cancer care continuum, starting from the prevention, the treatment, and the palliative care, also touch the research and innovation that, for example, in personal medicine and tele-digital health, we are developing. So it's important to involve patient voice, not only for consolidate clinical activities and management, but also to introduce innovation, to integrate innovation and new implementation, to guarantee the accessibility, to guarantee the quality of treatment that impacts in the quality of life of the patient and their relatives. Thank you very much for your attention.
My name is Chinyere Sam-Okerenta, a PhD researcher at University of Huddersfield, United Kingdom. I'll be speaking to us on the exploration of cancer survivorship experience of support and care continuity among UK Black, African, and Caribbean cancer survivors and their family caregivers. I'll briefly talk about the background of my study and then the research of the study, and I dwell more on study one and the research outcome. We all know that due to improved technology and early detection of cancer, more people survive cancer, and there is increased number of cancer survivors globally. And these cancer survivors are faced with some challenging symptoms from the cancer treatment. But the good news is that in the United Kingdom, the National Health Service provide free support to these individuals to manage the cancer symptoms, the treatment symptoms. However, when these individuals are stable, they are discharged into the community for self-management, supported by community organizations like Macmillan and their family members. However, these community organizations have reported that individuals from our target population are less likely to access their support. So the questions are, this support service is free. So why don't the Black, African, and Caribbean cancer survivors in the United Kingdom access these services that are free? And what are their support networks if they don't access such services? Imagine you come to the end of your initial cancer treatment. Instead of feeling excited, you're feeling frustrated, you're feeling weak, and independently you cannot manage yourself. And somebody is offering you a free service to help you, and you are not attending such groups. So I carried out a scoping literature review and actually found out that, of a fact, this group do not attend support services in the community. But I also find out another interesting thing, that nobody has actually explored why they don't attend such support services. And nobody has explored the challenges faced by their family members. So here comes in my study, trying to provide possible answers to these questions. So I carried out 2 qualitative studies. Study 1 was an individual face-to-face interview with visual aid carried out in the community among individuals that have finished their first cancer treatment. And study 2 was exploring the findings from study 1 with cancer stakeholders in England. But today I am presenting my study 1. So the aim was, I wanted to find out the support, explore the support and care continuity among Black cancer survivors in the United Kingdom. I also wanted to identify the networks they use. I also wanted to find out the needs and challenges their family members face, because they are likely to fall back on their family members if they don't attend such support services that are available. Like study 2, which I said explore the, I tried to understand the challenges the stakeholders also face in trying to reach this population, but I am not presenting that today. I said study 1, I recruited from the community 10 participants, 5 were Black cancer survivors who identified 5 caregivers, and it was a recorded interview which I transcribed and analyzed myself. During the interview, the participants were engaging because of the visual aid used. In my target population, cancer is a topic that is not easily discussed. So with the use of the picture technique, they were able to kind of be the driver of the interview, because they produced a representation of their experiences, and they were encouraged to identify the individuals and the groups that supported them while they were passing through those symptoms, and place it on this white sheet, and that helped them to discuss. So all we did was, oh, this person is on your chart. What did the person do? What kind of experience do you have with their own support? And that helped me to collect my data. So analyzing the data, 5 themes jumped out. One was feeling ambivalent with cancer support services. Some of them felt they were abandoned and they were not informed. They were excluded from formal services. They didn't have a good transition. And they felt that after the treatment, every care stopped and nobody signposted them to any navigated them to any group. Some also felt challenged to accept the new self in that they became dependent on others. They couldn't understand what was going on with them. They struggled, and some of them felt humiliated because they couldn't do what they normally do freely before. Another one was they said they depended more on their family. So the team, My Family, My Pillar, was identified from quotes like, my family, my church were my main support. My family were like a shield and strength around me. My husband, my child, my children were there for me. So if you look at the left side, you see the yellow blocks. Those are the themes, and the ones on the right, white blocks are the quotes where the themes came out from. And fourthly, they felt they were identified with their culture. And because they are Black, they felt different when they attended some of the support services they were able to find out by themselves. And they call it's an European thing, it's a closed thing, that they needed to justify themselves in the groups before they are accepted. So some said, oh, they picked up flyers for support groups, but they didn't see themselves identified in those groups because the flyer doesn't relate with them. And even one said when she attended one of the support services that she was given artificial breast with a different skin tone, a clear skin tone, which is different from her skin color. So they felt that the available services were not culturally sensitive to them. And finally, they felt, oh, I'm a child of God. I have beat cancer. God will not let me die. So they prayed, they fasted, they took Holy Communion, they read their Bible, and they felt that their faith played a major role in their experiences of cancer survivorship. And from the caregivers, almost the same themes also were identified. One, they felt lost and abandoned. Some of them said that the healthcare professionals never spoke to them. They were all focused on the cancer patient. Nobody cared about their unstable mood, their emotional challenges. They felt abandoned. Nobody signposted them to any group for caregivers. So they felt they were lost in the journey. And again, the second team also said, identified that they also struggled to live with this new person. Oh, my father, I saw it became different after the treatment. The things he normally would do, he was not able to do them again. So they viewed their relative as a new person, and it was challenging to them how to support that person, and because they felt they were never the same again. Then the third one, for them, culturally in the Black group, it's a cultural thing. It's traditional that you look after your ill patient, ill relative in the family. So it was difficult for them to accept the caregiver identity. Why would you call me caregiver? It's my wife, it's my husband is ill. It's my responsibility to look after him. And again, they had these emotional challenges. They felt they needed help from the help and support from the healthcare professionals, which they felt abandoned, and that also was a problem. Then they needed culturally tailored services, because one said, oh, they undressed my dad in my presence. I was not supposed to see my dad's nakedness in my culture. So they felt that the providers were culturally insensitive to them, and they cried out for cultural sensitive services. And finally, they also, like the survivors, said that their family and their church, their families and their church were their main support, were their pillar, who came to support them in their journey as caregivers. So in my research, I found that I've provided an insight into the cultural dimension of cancer care in the UK. I've also shed light on the challenges faced by Black cancer carers in the UK. I've also provided information for NHS strategies to improve health inequalities in the UK. I've also made some recommendations for navigation services for Black cancer survivors and their family at the end of the treatment, to navigate them to where they can access a culturally sensitive service. And also, my study has contributed methodologically, because I use the pictorial technique, and that, to the best of my knowledge, was the first time such technique was used in my target population. So in summary, I've identified that Black African cancer survivors in the UK also suffer from side effects of cancer treatment, and suffer with incapability of carrying out their activities. I've also identified that they feel culturally excluded from services and cried out for the need for cultural sensitive services for themselves. Then there is also need to improve how NHS provides the services for them and make it accessible to my target population. Thank you.
This presentation is about a systematic review on interventions to improve cancer survivorship among Indigenous people. My name is Wendy Gifford, and I'm an associate professor and Loyer de Silva Research Chair in the Faculty of Health Sciences at the University of Ottawa. I'd also like to introduce Peggy Dick from the Algonquins of Pikwakanagan First Nations, who is a partner on this work and will be with us live during the presentation.
And my name is Shoukoufeh Modanloo. I'm a postdoctoral research fellow working with Dr. Gifford at the University of Ottawa.
So to begin, we would like to acknowledge the land that we and the University of Ottawa are situated on, the traditional and unceded territory of the Algonquin Anishinaabe Nation, whose presence here reaches back to time immemorial. I would also like to acknowledge the co-authors on this work that was recently published in May 2021 in the MASCC Journal of Supportive Care in Cancer, and the citation is listed below. So to set the context for this study, worldwide, Indigenous people have a higher cancer burden than their non-Indigenous counterparts, and this includes higher rates and lower 5-year survival. The underlying causes are complex and include lower rates of screening and late-stage diagnosis. More pervasive reasons, however, stem from the colonial legacies that have created poverty, social exclusion, and systemic racism. And this has led to a lack of trust and engagement in Western healthcare systems, a lack of culturally safe cancer survivorship interventions, and non-representation of Indigenous values and distinct needs within mainstream healthcare and research. So the purpose of our study was to synthesize the research evidence on cancer survivorship strategies that have been utilized by Indigenous people. And we did our specific study objectives in our systematic review was to identify the methodological approaches that were used to describe the interventions and their relevance to Indigenous communities, and to examine outcomes and their positioning to holistic wellness.
Okay, so we conducted a systematic review of the quantitative and qualitative evidence. So to do so, we searched into 7 different databases. Also, we looked into the reference list of eligible studies. Out of almost 8,000 identified records, 27 studies were included. Studies were eligible to be included if they engaged Indigenous cancer survivor or caregivers. They had psychosocial cancer survivorship intervention, and they reported patient outcomes and collected data, primary data. We also assessed methodological quality and relevance to the Indigenous community. At the end, we synthesized the final result and reported narratively. To synthesize the component of the intervention, we coded the data into aimed framework, which included the aims, target population, ingredients, and delivery methods of each intervention. To measure the outcomes, our partners from Pikwakanagan First Nation, Peggy and Maggie, helped us to categorize the outcome into 2 categories of holistic wellness outcomes and responses toward the intervention that may influence the wellness outcome. This holistic wellness outcome were based on Indigenous wellness health into 4 categories of physical, mental, emotional, and spiritual health. The result of the study characteristics showed that 27 studies included. These studies involve 20 different interventions. Most studies conducted quantitatively, and most studies conducted in the United States with Native American. Majority of the studies, 81%, published in the last 10 years. We also measured the relevance of research to community. To do so, we measured the evidence of indigenous participant engagement in the research with using tools inspired by Smiley. This tool had a 0 to 8 Likert scale that categorized the relevance to the community through 4 categories of alignment of study design and measures to community values, belief, and knowledge system, alignment to local priority, and relevance of intervention to community. Also, if the protocol of the study was vetted by the community members. Most study in this systematic review ranked average in terms of the relevance to the community. Some example of this evidence of relevance were when research collaborators from community were engaged, when the tribal leader and indigenous health organization were consulted from onset. In terms of the aims and the ingredients of the intervention, the study results were diverse, but majority of the aims fell under 4 general categories of supporting the cancer journey, increasing knowledge, providing psychosocial support, and promoting dialogue about cancer. We identified 7 different ingredients, out of which community meetings, patient navigation, and art-based method were the most commonly used.
So for the outcomes that we looked at, 89% of the studies showed that the intervention had a positive effect on the outcomes measured. And these outcomes included cancer screening, referral rates, knowledge about cancer, and social or spiritual support and anxiety. When we categorize the outcomes into the holistic wellness categories, it turned out that 52% of the studies actually evaluated a physical aspect of health, and only 2 studies included a spiritual aspect of health in what they evaluated. 12 of the studies evaluated participants' responses towards the interventions, and this revealed that the interventions were considered culturally safe with relevant content. However, there was unresolved tensions between Western and Indigenous peoples' perceptions on how to deliver the intervention. So our study has revealed some of the differences between Western biomedical science and Indigenous epistemologies. Many of the studies use data collection methods such as surveys that do not typically represent Indigenous approaches to knowledge development. For example, the Warson study reported that participants responded positively to the arts-based intervention, but they were not receptive to completing the survey as the outcome measure. Interviews, discussion groups, and art are more consistent with Indigenous approaches to knowledge sharing. So in conclusion, these studies represented a small number of Indigenous people and did not meet relevant standards in reporting engagement with Indigenous communities. The studies predominantly focused on the physical aspect of wellness as an outcome, which is consistent with Western biomedical healthcare perspectives, but not consistent with concepts of holistic wellness from Indigenous ways of knowing. Cancer survivorship interventions need to be culturally safe, effective, and honor diverse concepts of Indigenous health. Thank you. We welcome comments or questions now.
Hi, my name is Elisa Fairchild, and I'm a radiation oncologist at the Cross Cancer Institute in Edmonton, Canada. I'm grateful to the organizers for inviting me on behalf of my colleagues to share our 10-year experience with an interprofessional supportive care studentship, teaching students to see through patients' eyes. I have no conflicts to disclose. Imagine you're in a busy clinic and you receive this assessment form completed by your patient. As a dietitian, nurse, or oncologist, you're well trained to assess and treat a few of these concerns, but clearly a team-based approach to care is necessary to address all of this patient's symptom challenges. Psychosocial support, symptom control, and palliative care are delivered at our institution largely by multidisciplinary teams whose members practice both discipline-specific and team process skills. These skills, though essential, are mainly learned on the job. In a field as complex and emotionally challenging as oncology, the optimal setting for interprofessional education, or IPE, for pre-licensure healthcare trainees is unclear, and literature describing long-term behavioral and attitudinal change is sparse. How can we prepare students to practice better multidisciplinary healthcare? The Sartori Studentship is a competitive 6-week IPE elective that places 2 students concurrently together from different disciplines per year. The students are introduced to challenges facing patients and families following a diagnosis of cancer through treatment, recovery, recurrence, palliation, and end of life, and incorporates features of best practice cooperative IPE learning. The studentship is focused on supportive care as delivered by a wide range of disciplines and in various locations. The vision of the studentship is twofold: to view the cancer experience through a patient's eyes and to view healthcare collaboration and service provision from the perspective of multiple healthcare disciplines. There are 5 educational components, which include mandatory and flexible clinical time, weekly facilitated reflective discussions, an exploratory investigation or research project, and a presentation on the research project and their clinical experiences. General surveys, as well as 2 validated questionnaires, are given to the students to complete at baseline, which is the first day, at 6 weeks, which is the final day of the studentship, and 6 months later. So this is an example schedule. This might be 1 week out of the 6 in which students attend chemo teaching, clinical nutrition inpatient visits. They may meet with a clinical ethicist, go to follow-up or new patient clinics, or do home care visits with palliative care in the community. In terms of results, over 10 years, we've had 150 applicants from 14 disciplines, ranging from social work to respiratory therapy to radiation therapy. And our 20 successful applicants came from medicine, occupational therapy, clinical nutrition, physiotherapy, nursing, pharmacy, speech-language pathology, and counseling psychology. Feedback from the students themselves have told us that this is a significant divergence from the regular curriculum and presents an opportunity for early professionalization through modeling and experiential exposure to common referrals. There's genuine patient perspective taking, and the co-student approach provides an opportunity for debriefing and connection, confirming that truly this is an exercise in empathy. From the point of view of the validated questionnaires, the first is the Interdisciplinary Education Perception Scale, or IEPS. This is an 18-item Likert scale, which is anchored from strongly disagree to strongly agree, and notably has no option to be neutral. This measures perceived competency within one's own profession, perceived need for interdisciplinary cooperation, the experience of actual cooperation, and willingness to understand the contributions of others. And larger scores indicate that the respondent thinks more highly of their own profession. In terms of examples, one question, question 6, asks respondents the degree to which they agree with the following statement: individuals in my profession need to cooperate with other professions. And you can see at all time points measured that there's general agreement amongst groups that this is important. Question 2, individuals in my profession are able to work closely with individuals in other professions, shows a bit more spread, between groups and between time points, although with general agreement maintained to 6 weeks and 6 months. Question 12, individuals in my profession make every effort to understand the capabilities and contributions of other professions. Here's where we start to see some splitting between the groups, with the medicine group being on the side of somewhat disagree versus somewhat agree, depending on the time point. And finally, question 11, individuals in my profession have a higher status than individuals in other professions, shows the greatest differences between groups and between time points. And you can see the medicine students strongly agree, whereas the rehab students strongly disagree at 6 months. In terms of the other validated questionnaire, we also use the Attitudes to Health Professions questionnaire, which notably measures attitudes towards other health professionals, whereas the IEPS, previously discussed, measures attitudes towards one's own profession. The AHPQ is a 20-item survey, which has both caring and subservient subscales, and each of the 20 questions maps to one or both of these. And attributes discussed include being confrontational, independent, vulnerable, caring, or gentle. Data is transformed such that the colder response has a lower value, and response values are summed for a total subscale score. You can see on the following figures that these are average results for perspectives on specific groups of students, and that the only results graphed on each figure are the results of the students who spent an entire summer with another student of that discipline. So for example, perspectives on the dietitian group show that at day 1, they're seen as very caring and somewhere in the middle of the subservient scale. At 6 weeks, they're seen as both more subservient and more caring, with 6 months a bit of regression towards the mean. Perspectives on the other group are shown in this figure, with the other professions, including nursing, pharmacy, and counseling psychology, who at 6 months are seen as both more caring and less subservient than at baseline. Perspectives on the rehab group are shown here, which demonstrate that at 6 months, they're seen as more subservient and more caring than at baseline. And perspectives on the medicine group are shown here. The medicine group were seen as the least caring and least subservient at baseline, with improvements in both at 6 weeks and relative stability at 6 months. In conclusion, our interprofessional multidisciplinary studentship is feasible, successful, and potentially generalizable to other academic settings. And trainees practice team process and clinical skills which are transferable to future placements and ultimately post-licensure practice. Participants are exposed to real-world multidisciplinary teamwork and gain intimate experience with patients and families challenged by cancer. Even over 6 weeks, objective perceptual change takes place, which appears to resonate long-term, although future studies are required that describe the integration of students within established multidisciplinary teams to confirm. We would like to acknowledge everyone listed on this slide, and most especially members of the Sartori family, without whose kind and generous donation, the establishment of the studentship would not have been possible. Thank you.
Ladies and gentlemen, dear colleagues, I hope you enjoyed this session and I hope you enjoy the rest of the conference.